mom pushed her.
Ma'am?
You all right?
Underwood, Chief Medical Officer of this hospital. How can I help?
I just want to take my daughter home.
Okay. We will get Christy out and we will bring her to you.
Let us
Yeah?
help you.
Right this way.
Okay.
This is your patient? Yes.
No, actually, it's my patient. She's been here for hours. Patients come in already in distress, and waiting only makes it worse.
Wait time has nothing to do with
Which
this.
is why we're seeing hospital workers like Dr. Collins get assaulted.
Just wanted to add that wait time definitely does make the patient more aggressive. I guess that's human behavior and stems from the frustration of having to wait more. Even seeing a lot more patients in a shift than we are normally used to makes doctors a bit more easily irritable than normal, and that's something I myself used to experience when I used to see more than 100 patients per day in the OPD when I was posted in medicine. But aggression is just next level, and I didn't like how the mom pushed the doctor who was just trying to intervene and help and calm down the situation.
Assaulted.
It was a little push.
Which we're going to take seriously. We risk our lives coming to work here every day.
I mean, couldn't agree more. Why not raise voice for the safety of doctors too? Where I was an intern, usually patients used to be brought up in a very critical state to the main hospital of our city when everything has already failed and the patient has been referred to the ultimate tertiary care center in their last stages. So these patients in ER used to be in states not salvageable with medications or surgery, and they used to die in the hospital beds, and the patient party used to get angry at the ER docs, and there used to be cases of violence against doctors and vandalism of hospital property as they used to blame docs for the loss of their loved ones. Also, many times there is violence against doctors due to miscommunication or lack of understanding, and both the medical team and patient party are to be blamed. One particular case I remember was a case of right lower quadrant pain of a female presenting in the ER. The surgery team clinically evaluated it as a case of acute appendicitis and took the patient to the OR. Counseling to the patient party was done accordingly. However, upon surgical exploration, it was found to actually be a case of ruptured ectopic pregnancy, and salpingectomy was done immediately where the ruptured fallopian tube was removed. However, the patient party wasn't informed of this while the operation was taking place. He was informed afterwards that a part of the reproductive system was removed surgically. The patient party was furious, not understanding that the surgeon saved his wife's life, and actually felt betrayed and blamed doctor for performing unnecessary surgery and removing a reproductive organ instead of the appendix, and soon it became local news. And all of this stemmed from the fact that he wasn't informed about the diagnosis beforehand and felt the surgeon was incompetent and performed some wrong unnecessary surgery on his wife.
What if that mother had brought a weapon?
We have metal detectors.
This is what happens when you keep all the hospital admissions stuck down here instead of properly staffing upstairs.
Too much crowd, too many patients, and the aggression and violence definitely does spill over amongst the frustrated patients.
I've got 4 patients waiting on ICU that have been here since before I got here, and it's already 1 o'clock.
I can see that
Got
you're...
4 more waiting on psych. One of them's been here for 5.
He must be talking about Kraken, who was the patient with methamphetamine-induced psychosis still waiting for a bed to open up in the psychiatry ward upstairs.
So please, for the love of God, hire more nurses.
I'll come back later.
That's not going to help anything.
It'll cost the hospital much more to add more staffs, more nurses, doctors, and more beds, and the administration would typically want the existing staff to make the best out of whatever is available at present while providing the least compensation possible to them.
Same thing every day. So, what brings you in today?
I averted my ankle playing table tennis.
Averted.
Yes.
You mind if I take a look?
Are you an orthopedic surgeon?
No, I am an emergency medicine specialist.
Could I talk to an orthopedic surgeon? I'd prefer an expert in that area.
Well, you landed in the emergency room first, so an ER doc has to check you first. A direct visit to an orthopedic surgeon would require an OPD visit, I guess.
Well, I'm pretty good at ankle sprains.
How do you know it's a sprain?
Well, I'd have to examine you first, but...
Could it be a Jones fracture or a dancer's fracture?
I think he's either a med student who knows something or just a nerdy patient who searches for every differential diagnosis of his health condition on the internet and overstresses about it. Jones fracture means fracture of the 5th metatarsal bone of the foot at the base of the little toe. It typically results from stress or trauma, such as a sudden twisting motion or direct impact. It's often seen in athletes, especially runners or basketball players, or those who have sudden changes in direction. Dance fracture involves the 5th metatarsal bone, particularly the base. The term dance fracture is more commonly used in dancers who perform jumps and land on their toes, putting significant stress on the forefoot. It's usually caused by overuse or repetitive microtrauma, which leads to the fracture over time.
Could be. Again, I'd have to look. Why don't I examine you, and that'll tell me...
Shouldn't you take a complete history on the present illness first?
It's okay and actually better for a patient to be aware of his health condition, but when they start to question everything you do with them, the oversmartness starts to feel annoying and rubs us the wrong way.
Sounds like you're more interested in asking the questions, so...
You didn't ask if I felt the pop or a snap.
A pop commonly refers to a sound or sensation in the joint or tendons, such as when a ligament or tendon moves over a bony surface, while a snap typically suggests a more serious issue. Snap is a sharp, sudden sound that can come from a tendon, ligament, or even bone. It often indicates that something has torn or ruptured, like a tendon rupture or ligament tear.
You didn't ask about previous injuries. You didn't ask about weight bearing.
Why don't I get
While it's important to ask all of these, the patient's examination part would be more useful along with relevant investigations.
you some fresh ice?
The patient has successfully annoyed his doctor away with his questions and skeptic demeanor.
Christy? It's Dr. Robbie.
No, I'm not leaving with her.
Your mom is not out here. Your mom is in the waiting room. Listen, I can put you in a quiet room. You can spend as much time as you want in there, but I cannot have you locked in this bathroom for safety reasons. Does that sound okay?
The hospital is really a dramatic scene. While some patients with psychosis have to be locked up in a room for safety of other patients, others lock themselves up like this out of frustration and anger.
Christy? Okay, I'm gonna open this door now.
Quiet room without my mom?
Of course.
It's a really tough situation to be as a teenager. The decision changes her life forever and there's no going back.
Lab is back on our 25-year-old. Sickle cell and cirrhosis both on deck for the ICU. Subway fall is next in line for the OR. And our good Samaritan with a head injury is waking up.
Oh,
He's alert with good parameters for extubation.
great.
The guy with an intracranial bleed, I guess. Good parameters mean his vitals, and likely the GCS score, which assesses a patient's level of consciousness. Extubation means his endotracheal tube is getting removed and patient would be checked if he's able to breathe on his own while maintaining the oxygen saturation.
Like Bradley's friends.
How did you get through the loss of a child?
The loss of a child is probably the worst experience of grief that a parent has to experience ever in his or her life. Losing a loved one who is older and had chronic diseases and was in a debilitating condition since a long time is somehow reconcilable, but losing a child, that too in a sudden fashion, is very difficult to reconcile and live with.
Same way you get through anything. By leaning on your friends and family.
How are they doing?
Still working through it. I'll let you know when it's time to revisit the organ donation conversation.
Okay.
They're shocked that their son will never come back to them, and talking about his organs being extracted from his lifeless body would definitely be felt as inappropriate right after he's been declared dead.
Any update on my abandoned senior Ginger?
I still haven't reached the daughter. I tried Ginger's son too. He was no help, lives in Cleveland.
It's disappointing. At least she's in good spirits.
I'm sure she appreciates the company, and her daughter Rita does need a break.
I just hope she comes back. And you know, I wanted to apologize about earlier. I spiraled. I occasionally jump to the worst case scenario.
And even I do that too. I guess it has its own pros and cons. The pro is that the shock factor when you actually land up in the worst case scenario would be a bit low, I guess. The con is definitely the overthinking and unnecessary stress that comes with it.
So
Understandable given what we see here. I'll let you know if I hear from Rita.
okay, thank you.
Hey, Mel.
Hey.
What's Mel short for? Melanoma? Melatonin?
Melanoma is a malignant tumor, meaning cancer of the skin cells, particularly melanocytes. Melanin is simply a brown pigment in the skin, present in melanocytes, while melatonin is a hormone that regulates our sleep-wake or circadian rhythm.
Melissa.
Yeah, I'm just messing with you. I noticed that you and Langdon have really been hitting it off.
Think?
Yeah. Have you noticed anything strange about his behavior?
Like what?
Anything at all?
Does she want to one-up the resident or something? That's weird.
I have noticed that he has a tendency to sweat a lot. I don't know if that's weird. It could be genetic.
Yeah, but just keep an eye out for me.
Why would she want to keep an eye out on her senior resident for an intern who doesn't get along anybody, basically due to her own ego?
Is everything okay, Dr. Langdon?
Oh, yeah. Got Dr. Google in Central 9 bombarding me with questions like my 4-year-old. I couldn't even get through a history.
Oh, so he's not a medical student? Even with Google, coming up with terms like history of present illness and past illness is a tough one unless you are really versed on those terms as someone in the medical field.
Is that his chart?
Yep.
Can I see it?
Knock yourself out.
Oh, he's autistic. Did you see that in his past medical history?
It's an ankle sprain. It has nothing to do with the injury.
Yeah, but it does have everything to do with how he talked and presented. Now, the inquiry and skepticism is understandable.
I could talk to him.
Great. I can see 3 other patients while you do.
How's my dad? He's still stable. His chest tube output has slowed down, which is an excellent sign.
If the chest tube output has slowed down, it just means that there is resolution of pathology, meaning if the bleeding from a traumatic hemothorax has stopped, the output will naturally reduce, meaning the hemothorax has resolved.
Thank you for taking care of him. Yeah, of course. Mrs. Dunn, can we talk for a moment? Excuse me. We found something in your husband's exam. He has some breast enlargement. Is that unusual? It depends.
So, she's trying to rule out the possible causes we detailed in the previous episode with history alone.
One common cause is alcoholism. Is he a drinker?
As pointed out in earlier episode, alcohol causes hepatocyte dysfunction and acute or chronic liver disease, which in turn causes decreased metabolism of estrogen in our body. Hence, the excess estrogen promotes the development of breasts, causing gynecomastia.
He has a few drinks every night. We'll do liver function blood tests for alcoholism. There's also disorders of the endocrine system, so we can check his hormone levels. Hormones?
Yes, so it's basically the interplay between estrogen and testosterone on breast tissue. Any disorder along the pathway of hypothalamus-pituitary-testicular axis can lead to decrease in testosterone or increase in estrogen or prolactin, leading to gynecomastia.
Go! Can somebody help me, please?
We need a wheelchair here. What happened?
I was on my way home and I saw her in the road. She was in and out of the intersection yelling at cars and people.
What's her name?
Nandi. She's my roommate.
Did she get hit? Her knees are all scraped up.
No, she tripped while I was...
So, right off, we can observe that she seems to talk to and respond to someone else and is likely hearing their voices. This is typical for an auditory hallucination, and it could be a component of psychosis or schizophrenia. Basically, psychosis includes symptoms like delusions, hallucinations, disorganized thought, speech, or behavior, and negative symptoms like withdrawal.
Pulling her out of traffic.
Does she have a psychiatric condition?
Not that I know of.
Let's get her in bed. You're okay.
Let me go!
She seems to probably not have insight of what's happening to her too, which makes the diagnosis of psychosis likely. So, a case of acute psychosis would ideally require first calming down the patient with benzodiazepines like lorazepam and likely antipsychotics like haloperidol, or we can just give olanzapine alone, kind of like the psychosis patient in the ER already.
Hi, Terrence. I'm Dr. King.
Hello.
Dr. Langdon is with another patient right now, so I'm gonna finish taking your history. Is that okay?
Sure.
Okay. It's a little bright in here.
So, the point here is that people with autism often have heightened sensory perception, meaning they may be hypersensitive to bright lights, loud sounds, strong smells, and touch. For them, a typical hospital with fluorescent lights, white walls, and equipment noise can feel overwhelming or even painful. So, it's prudent to tone these sensory stimuli down for making a patient with autism comfortable.
Oh, that's... Sorry, the ER can be very noisy.
The hospital as a whole is a bright, noisy place overall. Reducing sensory input also helps lower the risk of emotional distress, agitation, or withdrawal.
I agree.
So I heard that you might have sprained your ankle playing table tennis?
I averted it.
Yeah.
Ankle eversion is basically when the sole of the foot turns outward, where the lateral or outer edge of the foot lifts up and the medial or inner edge presses downward toward the ground. This occurs when the deltoid ligament, which is a strong fan-shaped ligament on medial side of ankle, gets injured and the foot everts. also called a medial ankle sprain. However, it's very rare as the deltoid ligament is very strong and resists eversion. What's more common is a lateral ankle sprain where the lateral ligaments get injured, causing inversion or inward turning of the foot.
What is your biggest concern today, Terrence? What worries you the most about your the pain in your ankle?
What worries me? Do you mean right now in this moment?
Right now.
I'm worried I won't be able to play table tennis if it's a bad injury. There's a tournament in 6 weeks and I already registered. It's my first tournament.
Autism involves altered brain development and wiring where some brain regions may be hyperconnected with too much local wiring or hypoconnected with too little long-range communication. Some individuals with autism seem to have extraordinary talent in a specific area like music, math, drawing, or memory, where there are hyperconnections in brain areas. While brain areas controlling social interaction, communication, sensory processing, and flexible thinking are hypoconnected, and hence they have deficiencies in these areas. Furthermore, the autistic brain often has enhanced low-level processing and pattern recognition. People with autism may focus intensely on one area, and by repeating, refining, and mastering a specific skill like piano, dates, maps, or sports technique, they become extraordinarily good at it, well above average.
Wow, that's a big deal.
Yes. The championship is hosted by the South Park Table Tennis Club. 9 players have USATT ratings over 2,000. 1,400 is considered average. 2,000 is a master player. My goal is to get a rating over 2,000.
Well, let's get you to that tournament then.
As we hinted before, the guy here is basically a nerd at tennis and is likely very good at it too.
So Terrence, would you walk around the room for me, please? I'll be able to tell a lot more about your injury.
A lot of ortho injuries can be diagnosed with the type and pattern of gait of a patient.
Hurts a little.
I don't think he does have a specific pattern of gait that's pathognomic to specific disease or injury. Maybe an antalgic gait, I guess, which is a walking pattern where the patient shortens the stance phase, that is, reduces the time spent bearing weight on the painful leg to avoid pain. The patient puts weight on the painful leg for less time and quickly shifts weight to the opposite normal leg.
How painful? On a scale from 1 to 10, 10's the worst.
The worst? The worst I've ever felt or the worst that a human being can experience.
Autistic individuals often interpret language very literally and want to fully understand the exact meaning. They may seek precise definitions to reduce ambiguity. This can look like over-questioning, but is actually a way to ensure clear understanding. They might not pick up on implied meanings, sarcasm, or conversational shortcuts, so they tend to expand on statements or seek more info rather than accept vague remarks. Here, the patient is trying to pin down exactly what worst means. Is it subjective or absolute? This helps him understand and respond appropriately.
A little pain is a great answer, Terrence. Thank you. Well, based on your walking around, I don't think it's a serious injury.
Likely an ankle sprain due to ligament injury while playing tennis.
You know what? There's actually something I want to show you. I'll be right back.
Ah! What was that?
It's olanzapine, 10 milligrams.
As discussed before, olanzapine is an atypical antipsychotic drug which is used alone for management of acute psychosis. We could also provide haloperidol with lorazepam combined too. However, do not combine olanzapine with lorazepam as the risk of respiratory depression is more.
Do you know any of her medical history?
No, we've only known each other for a few months. We're both influencers. We met online. I thought it would be a good idea to live together.
When did she start behaving differently?
About a month ago. She's been up at all hours talking to herself nonstop.
This strongly suggests auditory hallucinations, and we've noticed this before too in the hallway. Talking to herself suggests that she's responding to voices, which is a hallmark of auditory hallucinations. Now, why not visual? It's because visual hallucinations are often reported directly as seeing objects that aren't there, and these don't typically provoke verbal responses. Here, although she might appear to talk to someone else and see them, but she's actually responding to the voices she's hearing in her own ears, and this is not her responding to seeing someone else visually. In visual hallucinations, the person may stare, track with eyes, or appear frightened or confused, but not usually talk back unless extremely distressed. It's important to note that auditory hallucinations are more common in schizophrenia, mania, severe depression with psychotic features, or substance-induced psychosis. It's often described as voices talking to the person, voices commenting on their action, or voices giving commands. And visual hallucinations are common in delirium, which is an acute, confusional, and disoriented state caused usually due to an organic cause, not a psychiatric one.
She's suicidal.
Psychotic patients are at high risk of suicidal ideation because of many reasons. The obvious one would be command hallucinations, where some auditory hallucinations tell them to kill themselves. These voices could be loud, persistent, and overwhelming, and patients may feel forced to believe bad things will happen if they disobey the voice and not end their life, as patients don't have insight of what's happening to them or what's real and what's not. Delusions can make them feel trapped or in danger of being persecuted, which is called the delusion of persecution. This can lead to suicidal ideation, where the patient feels they need to end their lives to be free from persecution or before someone harms, threatens, or targets them. Also, there is something called post-psychotic depression, where after a psychotic episode resolves, many patients experience a deep depression and shame about what happened. If the guilt overwhelms them, they might commit suicide.
Any drug use? No, I don't think so.
This is asked to rule out substance-induced psychosis, common examples being methamphetamine, cocaine, cannabis, or even alcohol. The rule of thumb in psychiatry is to ask about suicidal ideation and substance use in almost every major psychiatric disorder like depression, psychosis, mania, or even anxiety.
Spotty, Whitaker, see if you can do the exam.
Can you look at the light?
No, what was that?
Okay. Open your mouth.
No, it's not real. Where am I?
How do you even do an exam with a patient like this?
The furniture's changed.
So, the patient is resisting pupil tests and oral examination because she feels threatened by these and doesn't want to cooperate. Might as well be delusion of persecution here. Also, there is disorganized thought and altered perception of reality, where the patient seems to think it's her room, which has been altered.
Observe her. Wait for her to look at you or open her mouth and get a quick look. Make sure she moves her arms and legs equally.
Checking for equal movement of both sides means to ensure the patient has equal strength and movement on both sides of the body. If one side is weaker or doesn't move well, it might suggest an organic cause of her symptoms like stroke or a brain lesion.
This is just to monitor your heart.
All right, we might need to wait until after the meds kick in.
Yeah, so wait until the antipsychotic medication calms her down and she becomes less paranoid and more cooperative for examination and tests.
Okay, differential diagnosis.
Schizophrenia, first psychotic break. She's in the right age range.
Yep.
Basically, all the causes we talked about of hallucinations, including schizophrenia. Schizophrenia is basically a chronic condition that features psychosis, while psychosis is a broader term encompassing acute causes too, like drugs. The most common period of onset of schizophrenia is teens to 30s.
What else?
Drugs also common in this age group.
Common in all age groups.
Stimulants like cocaine and methamphetamine, hallucinogens like LSD, psilocybin, and ketamine are known to cause psychosis. Also, cannabis can trigger or worsen psychosis, especially in teens or those with a genetic risk, and is strongly linked to first episode psychosis in young adults. Alcohol can also cause psychotic symptoms like visual and tactile hallucinations, which are common features of delirium tremens, a complication of alcohol withdrawal.
What else?
Not just recreational drugs, could also be toxicity to medications.
So prescription meds can also cause psychosis like steroids or dopaminergic drugs used to treat Parkinson's disease like levodopa or anticholinergics.
Don't jump to conclusions, think big categories and then specifics.
Metabolic, hyper or hyponatremia, calcium, hepatic encephalopathy.
Endocrine, hyperthyroid, infectious encephalitis.
So there could be metabolic causes like hyper or hyponatremia, hypercalcemia, hypomagnesemia, and hypoglycemia. Endocrine causes like hyper or hypothyroidism, Cushing or Addison's disease with increased or decreased cortisol levels, and hypoparathyroidism with low parathyroid hormone levels, hepatic encephalopathy with increased ammonia levels toxic to brain, uremic encephalopathy with uremic toxins due to renal failure affecting the brain, systemic infections leading to CNS infection, or even nutritional deficiencies like that of vitamin B1 or thiamine causing Korsakoff psychosis.
Those are all possibilities. Okay, let's work her up medically and see if we can clear
Chem panel, CBC, TSH, and T4.
These are all tests as part of a classic initial medical workup for new onset psychosis or altered mental status in the emergency department. Chem panel, like basic or comprehensive metabolic panel, includes checking for electrolytes like sodium, potassium, calcium, glucose, renal function tests like urea and creatinine, and liver function tests like ALT and AST. Complete blood count is basically ordered to check for increased or decreased WBC levels to rule out infection. TSH and T4 are for ruling out hyper or hypothyroidism, both of which can cause psychosis.
Drug screen and HCG.
Urine drug screen is done to detect drug metabolites in urine and rule out substance-induced psychosis. Beta HCG is checked for in urine. In all women of childbearing age before giving antipsychotics or benzodiazepines, as these are potentially teratogenic and are to be used in pregnant women with caution.
Yep, keep me posted. If it's all negative, then admit her to psych.
It's important to note that all of these are secondary causes of psychosis and hence are primarily medical disorders with psychotic features, hence dealt with by the medical team first. Also, these could also cause delirium, which is an acute confusional state where there is fluctuating disturbance in attention and awareness, often with changes in cognition like memory, disorientation, or language. This is an organic disorder, again dealt by medical team. Usually, these organic causes are ruled out first. Then if there is no medical cause of the symptoms, then only it's referred to psychiatry, citing a purely psychiatric cause of symptoms.
Still feeling nauseous?
Not really.
Good. So, your mom is looking for you.
I didn't think my mom would find out. If I go home with her, my life is over.
Maybe she'll change her mind.
Unfortunately, there's nothing more a doctor can help with in this situation except for comfort and reassurance that everything's going to be fine.
Sometimes this tendon called peroneus brevis can pull off a piece of this bone, the fifth metatarsal.
Great teaching here with the bone model to a patient who is curious. So forceful inversion of the foot causes the peroneus brevis tendon to pull on its insertion at the base of the fifth metatarsal. This leads to an avulsion fracture of the tuberosity of the fifth metatarsal. This is called a dancer's fracture, as it's commonly seen in dancers who perform jumps and land on their toes. And if they invert the foot forcefully in the process, it could potentially cause this fracture.
That's the dancer's fracture, right?
Exactly. You most likely have a second-degree ankle sprain.
A second-degree ankle sprain refers to a moderate injury to the ligaments of the ankle, more severe than a mild that is grade 1 sprain, but not a complete tear that is grade 3. Here, there is moderate pain, swelling, some bruising, limited function with mild joint laxity. The treatment would include RICE, meaning rest, ICE, compression with wraps and elevation, along with pain meds and physiotherapy. Most recover in 2 to 6 weeks with proper care.
The x-ray will tell us everything. Tech will come get you, and then I'll come back and show you the images.
A dancer's fracture is seen on X-ray as transverse fracture at the base of fifth metatarsal, while Jones' fracture would be seen as a transverse fracture 1.5 to 2 centimeters distal to base at metaphyseal-diaphyseal junction.
Great.
Okay. I'll put the orders in.
How'd you do that?
Do what?
Talk to him.
I listened?
Funny. No, you unlocked something. I wasn't getting anywhere with them.
I guess she knows how to talk with a patient with autism empathetically.
Oh, my sister is on the spectrum, and the ER can be a very, very overwhelming place for autistic people. So I don't know, it just takes a different approach.
Yeah, definitely. ER is a very bustling and busy place to be in, with all kinds of people all agitated and desperate for help, and it's definitely overwhelming for someone who has difficulty interacting with people.
You and your sister close?
Yeah, we're best friends. There's this one time we were on the swing,
I gotta hit the head.
and then
Let me know when the x-rays are back.
Huh?
Where is she?
She's okay. She just needs a minute.
I have given her enough time. She can process this on the car ride home.
Can we talk for a moment? Please.
I know you're trying to help, but this is really between me and my daughter. So if you could just bring her out, we will be on our way.
I guess the root cause of why she doesn't want to allow the medical termination of pregnancy of her daughter is still pending.
She's really upset.
She'll get over it.
Weren't you about the same age when you got pregnant with her?
Yes.
So you know how hard it can be.
It was very hard at the time. But she turned out to be the best thing that has ever happened to me.
And I hope she feels the same way when she's ready, but right now, she's not. For her, the world is ending. If you push her away, she might never come back.
Yes, life experiences do change unexpectedly, like for the mom here who eventually embraced the teen pregnancy, but as of right now, the daughter's mental health is deteriorating with just the idea of continuing the pregnancy.
Dr. Collins?
Excuse me.
Code STEMI, trauma 2 now. Code STEMI, trauma 2 now.
Hey, need a hand with the STEMI?
We're all set. Whitaker, you're with me.
Trauma 2? Brought in by a coworker after 10 minutes of substernal chest pain with diaphoresis.
Substernal chest pain radiating to the jaw and diaphoresis or sweating along with shortness of breath and nausea are classic symptoms of myocardial infarction or a heart attack. It occurs as the myocardium or the heart muscle becomes deprived of blood supply and dies due to blockage in a branch of coronary artery supplying that portion of the myocardium.
Anterior STEMI and triage.
An anterior ST elevation myocardial infarction is caused by occlusion of the left anterior descending artery, which supplies the anterior wall of the left ventricle. ECG would typically show ST elevation in leads V1 to V4, where V1 and V2 indicate the septal wall and V3 and V4 indicate the anterior wall involvement. As myocardium is dead here, cardiac markers like troponin would be elevated, confirming the infarction.
Dr. Santos, do you have a minute? Yeah, sure.
I'm Dr. Langdon. This is Dr. Robbie.
Harvey Ting.
You're having a heart attack, sir.
I figured.
You ever had one before?
How much pain?
Like an elephant's on my chest.
Are you taking any medications?
Metformin and rosuvastatin.
Metformin is an oral anti-diabetic drug commonly used to treat type 2 diabetes, while rosuvastatin is a statin, a class of anti-hyperlipidemic drug used to lower cholesterol levels in blood.
170 over 92 at triage.
He's definitely hypertensive here.
324 chewable aspirin sublingual nitro Q5 times 3.
To treat a case of acute MI, we basically start with morphine to relieve the excruciating substernal chest pain, provide oxygen if SpO2 is less than 90%. We give sublingual nitrates, which basically cause venodilation and decrease cardiac preload, to be given sublingually and repeat every 5 minutes for maximum 3 times. Aspirin 324 milligrams to be chewed, along with clopidogrel 600 milligrams loading dose, both of which are antiplatelet drugs used to inhibit platelet aggregation and prevent further clots. Primary PCI or percutaneous coronary intervention is to be done best within 90 minutes of arrival, and if PCI isn't available and takes more than 2 hours, we could thrombolize the patient with fibrinolytics like alteplase. I guess the door to balloon time Dr. Langdon is trying to achieve is less than 30 minutes, which is well within the standard 90 minutes.
Cath lab is standing by and ready.
Harvey, if we get you up to cardiology, they can open your blocked artery, we can stop this heart attack.
In PCI done in a cath lab by interventional cardiologists, first of all, a catheter is inserted into a blood vessel, usually the radial artery or femoral artery. Then, contrast dye is injected into coronary arteries, and X-ray imaging or fluoroscopy shows the location and severity of blockages. A balloon-tipped catheter is then advanced to the blockage, and the balloon is inflated to compress the plaque and open the artery. As balloon inflates, the stent expands and stays in place to keep artery open. The balloon is then deflated and withdrawn while the stent remains permanently in the artery, preventing future stenosis.
Anyone got a score for the Pirates game?
They're up by 2 at the bottom of the first. Concussion hit Apo Taco.
Clutch.
Is there anybody we can call?
My wife died a year ago. I guess today's the day I'll be joining her.
Oh, I appreciate that sentiment, but that is not part of our plan.
No murmurs, radial pulses are symmetric.
A heart murmur is an extra or unusual sound heard during a heartbeat, typically caused by turbulent blood flow through the heart valves, usually heard in valvular heart diseases or congenital heart defects.
VFib.
The anterior wall STEMI just complicated into a cardiac arrest rhythm called ventricular fibrillation. It's a life-threatening arrhythmia with disorganized, chaotic ventricular electrical activity where there is no coordinated contraction leading to no cardiac output. It leads to sudden cardiac death within minutes if not treated. Hence, it has to be immediately treated with defibrillation with unsynchronized DC shock 200 joules biphasic. Also, CPR is to be given along with epinephrine, 1 milligrams IV every 3 to 5 minutes.
Whitaker, chest compressions, charge you 200. Best way to face your
I
fears.
can think of better ways.
Let's back up on 100%. Set up for intubation.
Charged and clear.
Still VFib. Resume compression.
So the pattern here is to provide chest compressions, then pause and provide the defibrillator shock, and then check for rhythm. If it's normal sinus rhythm, the VFib has been successfully reverted and the electrical cardioversion would be said to have been successful. If not, CPR is to be resumed again.
Let's get him on the Lucas.
Lucas or Lund University Cardiac Arrest System is a mechanical chest compression device used to deliver automatic rhythmic chest compressions.
As soon as we know anything, I'll come and get you.
This is all my fault.
What is? Is there something you haven't told us? Mrs. Dunn, in order to effectively treat your husband, we need to know anything that...
The hormone levels. It could be the progesterone.
He's taking progesterone?
I've been giving it to him. I put it in his coffee every morning.
So the husband has been drugged, and the progesterone has been acting on the breast tissue to proliferate it and develop gynecomastia.
I thought if I could kill his libido, we'd stop.
Progesterone would inhibit the release of FSH and LH from the pituitary via negative feedback, which would in turn decrease the endogenous production of testosterone, hence likely decreasing libido and achieving the desired effect here, which is...
Stop what?
I think he's molesting our daughter.
It's heartbreaking to see what sort of inhumane and unimaginable behavior people have to endure in their lives, and how desperate one must be to stop all the bad things happening around them, hence leading to the step that mom took to prevent it. This has definitely turned the case upside down into a pretty serious medical legal case, and it wouldn't even have surfaced had the doctor not inquired to the wife about the husband's gynecomastia.
Whitaker, on life pack, you need to learn this.
Yeah.
Set 200 joules asynchronous.
It's important to note here that synchronized DC shock is given for arrhythmias like atrial fibrillation, atrial flutter, supraventricular tachycardia, and ventricular tachycardia with a pulse. Here, the electrical discharge is synchronized with the patient's cardiac cycle, specifically the R wave, to minimize the risk of triggering ventricular fibrillation. And as we know already, asynchronous DC shock is given in shockable rhythms of cardiac arrest, namely ventricular fibrillation and pulseless ventricular tachycardia.
Press charge.
Pause compressions.
Still VFib.
No pulse. Clear?
Clear.
That's your cue, Whitaker.
Shit.
So, after 2 minutes of CPR, again again round of defibrillator shock is given. Again, if there is no sinus rhythm or a palpable pulse, we gotta resume CPR and administer epinephrine 1 milligrams IV. Again, after 2 minutes, we provide another round of shock and then check. If the patient is still in cardiac arrest, we provide amiodarone 300 milligrams IV bolus and continue CPR and epinephrine. We continue this cycle until the return of spontaneous circulation occurs with restoration of sinus rhythm and a palpable pulse.
No change. Epi and amio, please.
He's not coming back, is he?
We still got a ways to go.
One of Epi's in?
One of epi means 1 milligram epinephrine provided intravenously and can be repeated every 3 to 5 minutes. And amiodarone is usually given as bolus 300 milligrams after the third shock.
Double sequential defibrillation next.
Worth a shot.
Double sequential defibrillation, or DSD, is an advanced resuscitation technique used for refractory ventricular fibrillation like this, when a patient remains in VF despite multiple defibrillation attempts, usually after 3 to 5 attempts. Here, 2 defibrillator shocks are delivered in rapid succession, almost simultaneously. It has 2 defibrillators with 2 pairs of pads, one set in the usual anterolateral position, and the second set often placed anteroposterior or in a different axis. Both shocks are delivered within 1 second of each other. Each defibrillator is usually set to 200 joules biphasic, so a total of 400 joules delivered from 2 vectors. So, in refractory VFib, the heart muscle may be unevenly depolarized and have areas not reached by a single shock vector. DSD increases the chance of complete myocardial depolarization and help reset abnormal electrical circuits more effectively than one shock.
Put in an art line.
Right sternal border, apex.
theory is that the first shock lowers the defib threshold, so that the second shock has a better chance of converting into fibrillating myocytes.
Yeah, you could say that as well. There is the multiple vector theory that states that different shock vectors can depolarize different areas of the heart, hence leading to more complete depolarization. We could also simultaneously say that the first shock partially depolarizes the myocardium, lowering the defibrillation threshold, which means there are still few fibrillating myocytes, but with reduced threshold for defibrillation. Now, the second shock, coming from a different vector, has a greater chance of converting those remaining fibrillating cells to a coordinated rhythm.
Mr. Wallace, how are you feeling?
I'm okay.
You've been here about 7 hours. Hit your head and came in unconscious. Took a pretty nasty fall.
The T?
Yeah, on the T-tracks.
It's great to see a head injury patient recover back to life and talk normally. It isn't as common, unfortunately.
What about the Asian lady? How's she doing?
Minu.
The Nepali lady with the degloved leg and associated open fracture, I guess. She should be in the ortho OR for the open reduction and surgical debridement.
She's doing a lot better.
Did the cops catch the guy who pushed her?
She was pushed.
A medical legal case again.
Yeah, I saw it.
The cops were here earlier. They wanted to talk to you.
I can give him a statement.
Okay. We can reach out.
Can I see her?
I think we can make that happen.
All right, Whitaker, if he's pulseless, we clear and then shock.
Yeah, so basically, pause the CPR, look for sinus rhythm on the ECG monitor, and try to palpate the pulse in the patient. If there is no pulse and no sinus rhythm, shock the patient, in this case, one after another in quick succession as a DSD.
I go first, you hit it as fast as you can.
I got it.
Charging both to 200.
Charged.
Pause compressions. No pulse on the A line, clear for the 1-2 punch.
Clear.
Resuming compressions.
So, there is still no return of spontaneous circulation and no sinus rhythm. We continue the CPR and repeat.
That was our Hail Mary.
We got one more. Activate ECMO.
ECMO stands for extracorporeal membrane oxygenation, which is a form of life support used when the heart or lungs are failing and need time to recover. It takes over the function of the heart and lungs by pumping blood outside the body, oxygenating it through a membrane, which is the artificial lung, and returning the oxygenated blood back into the body. It's often used in massive MI with cardiogenic shock, or in case of cardiac arrest like this case, or in case of severe ARDS too.
Okay, drop an ABG, prep the FEMS, Cordis introducer.
ABG means arterial blood gas analysis, where we draw arterial blood and test for blood pH and partial pressure of oxygen and carbon dioxide along with bicarbonate levels, basically to check for acid-base balance in the body. Cordis is a large bore venous catheter used in ECMO cannulation, typically inserted into a large vein like the femoral vein.
Get the ECMO team down here.
Feeling any better?
Maybe. Less.
Olanzapine has kicked in. Typically, its onset of action is 5 to 15 minutes, potentially halting the acute episode of psychosis.
Is there anybody we can call? Your friend had to leave, but we can give her an update.
Karis. She's not really a friend. I don't have friends. Just followers.
Internet fame, money, loneliness, drugs, and mental health issues like depression, anxiety, and psychosis all are well interconnected with each other in a sequence and could very well be the case here.
So you're on TikTok?
Of course. I'm a beauty influencer.
Like makeup tutorials?
Makeup, skincare, hair.
What's the most amount of views you've ever gotten in one of your videos?
2 million.
2 million? Okay, I need to follow you.
Nandi, why did you wander into traffic today?
I was afraid of people coming after me. I don't feel safe at home.
Who's coming after you?
I don't know.
This is likely delusion of persecution here, as pointed out before, the false fixed belief that someone is trying to harm, harass, spy on, or conspire against the person, even when there is no evidence. It's a common type of delusion seen in psychosis.
Something changed.
When?
Maybe a month ago.
What changed?
I can't remember. I was worried all the time. Trouble sleeping.
What about physical symptoms? Pain, aches?
Psychiatric illness do present with physical symptoms as well, and these aren't explained by any other medical cause. This is called somatization and can be seen with any psychiatric illness such as anxiety, depression, psychosis, conversion disorders, just to name a few. The somatic symptoms could be anything like fatigue, aches, GI pain, headache, palpitations, chest pain, or shortness of breath. Some psychiatric disorders have physical symptoms as the primary symptoms, which we call as somatoform disorders. This could even include neurologic deficits like paralysis and blindness in somatoform disorders like conversion disorder.
My hands shake. Can't even put on makeup. My feet get numb.
Going into the specifics, the symptoms she's experiencing like tremors or trembling of hands and numbness of feet could be symptoms of a CNS disorder, could even be stemming from a brain lesion or a stroke. I guess further physical examination and CT head should be done in priority along with all the other tests noted before saying that these are somatic manifestations of a mental illness, because they could very well be coming from an organic cause like a brain lesion.
What else?
I don't recognize myself in the mirror sometimes. I feel like I'm in a dream and nothing is real.
So a little bit of clarity is needed here. We do say that psychotic patients lack insight, meaning they lack the awareness of their own illness and can't identify what's happening to them. But this is during the episode itself. However, as the episode subsides, the patient might have full insight about their illness and realize it was part of a mental illness, or they might have partial insight where they would recognize some aspects as unusual but may still hold on to certain beliefs or feel unsure. They often can remember what happened but can't make sense of it at all, exactly like in this case, or the patients do not regain any insight at all. There is partial insight here. Since she is able to recognize something changed, she can remember but can't make sense. She says the world feels unreal. This is called derealization, which is a dissociative symptom where the world feels unreal, foggy, or dreamlike. Also, up to 25 to 50% patients go through post-psychotic depression where they may feel emotionally flat, ashamed, and isolated.
What's happening to me?
We don't know yet, but we're gonna do more tests.
These tests are to rule out all the possible medical organic causes of psychosis before concluding that it's a purely psychiatric episode of psychosis and handing over the case to psychiatric team.
Any ideas?
Call for a psych consult?
Let's ask for a head CT with contrast first.
Exactly as we said before. Rule out CNS causes of the symptoms first.
Looking for what?
Tremors, coordination problems. Frontal lobe lesions can cause behavioral changes.
Yeah, definitely it could. Apart from this, intentional tremors and coordination problems could stem from a cerebellar lesion too, as cerebellum is responsible for coordination of movements. The tremors here are intentional, meaning they start as we try to initiate movement and try to grab or reach something. Additionally, it could be a lesion of the basal ganglia too, another important gray matter area in the brain responsible for coordination, whose lesion can also cause resting tremors, meaning tremors occurring even at rest, along with slowed movement, or bradykinesia along with rigidity, basically causing Parkinsonian features.
We can't assume this is all psych.
Got it.
I've got a 7 French quartus in place.
So, the femoral vein has been cannulated here for central venous access.
Robin.
Here we go. ABG.
ABG is basically looked for before ECMO to have a baseline assessment of acid-base balance in the body and determine the severity of respiratory or cardiac failure.
Looks good. Let's do this.
I accessed the right femoral vein.
Thanks for that.
So, Whitaker, we treat this like a sterile surgical procedure. Can't introduce bacteria into the circuit.
Sterilize the area with povidone iodine. We can see a catheter is already in place in the right femoral vein. Basically, there are two types of ECMO. The venovenous ECMO is where blood is drawn from a vein, like femoral, and returned to another vein, like the internal jugular. Here, the ECMO does the job of the lungs as the membrane oxygenator adds oxygen and removes carbon dioxide out of the blood, and the oxygenated blood is returned back to a vein to be pumped by the intact heart throughout the body. Hence, it's useful only in conditions with severe respiratory failure where the heart is still intact and functioning well. However, the one which is likely needed in this particular case of cardiac arrest is the veno-arterial ECMO. In a veno-arterial ECMO, the blood is drawn from a vein and returned to an artery. For example, blood taken from the femoral vein is oxygenated and is pumped back into the femoral artery. Here, the ECMO functions both like the heart and the lungs. So it's useful in cardiac arrest and other causes of cardiogenic shock like MI. Since it bypasses both the heart and the lungs, it does both their job, hence is useful in cardiopulmonary failure and could be used as a last resort when CPR has failed. In this case, it's also called extracorporeal CPR, where a veno-arterial ECMO is initiated during ongoing chest compressions to artificially support the heart and lungs when standard CPR fails to restore circulation.
He'll get a garden hose coming out of the vein at the right leg that flows into the ECMO machine for oxygen and gets pumped back through a second hose into the left femoral artery.
These guys are impressive.
The ECMO does all the work of the heart and lungs.
It's important to note that this is not routinely done and only done in select patients with fast ECMO team access and if the cardiac arrest was immediately witnessed with little to no downtime. Also, this is basically trying to buy time for the patient's heart to resume working by essentially doing its work artificially, and this could only last for so long.
Place an IG at the neck, they'll want that.
Got it.
He's likely referring to an internal jugular vein cannulation as well in the neck for another central venous access to monitor central venous pressure or give meds or fluids as required.
Okay, I think there's enough warm bodies in here. I'm gonna go check on the rest of the department.
You don't want to hang out until...
These guys know what they're doing.
Dr. Robbie?
Yep.
Can we talk about the patient in Trauma 1, Silas, the fixer-upper who fell off the ladder?
Are his labs back yet?
No, but his wife, Susan, told me that she's been putting progesterone in his coffee.
Progesterone? Why?
She wanted to kill his sex drive. He's been sexually assaulting their daughter.
As we said before, you never know how a medical case would take unexpected twists and turns. Every medical case is a story, and there could be underlying stories to each individual medical story. You just gotta be vigilant and investigative enough medically to unravel these stories.
Shit.
Well, we don't know that.
What exactly did the wife say?
He goes into the kid's bathroom when she's showering, gives her unwanted massages. Her behavior's changed. She's struggling in school. The mom is really worried.
But she hasn't talked to her daughter about any of this, doesn't want to put ideas in her head.
It's grooming. And we are mandated reporters of child abuse in Pennsylvania.
There's nothing to report unless we have proof. Right now, it's all speculative.
If a doctor sees signs or has reasonable suspicion of physical, emotional, sexual child abuse or child neglect, they are legally obligated to report it to Child Protective Services. And it's necessary to report it even if there seems no signs or proof, but the suspicion is reasonable and high. Here, the suspicion of child abuse is from the words of her mother, and a complete history and medical examination of the daughter would yield even more evidence, I guess.
Are we obligated to report mom for poisoning the husband?
Unfortunately, yes.
There are two medical legal aspects of this case. The one being the husband being drugged with progesterone, and the other is the reason for the former, which is the alleged child abuse.
She's not trying to kill him. She's just worried about her daughter.
He fell off a ladder, he broke a bunch of ribs. You're the one who's treating him. What if next time it's worse?
Progesterone could cause serious complications apart from just gynecomastia, which could include thromboembolism like deep vein thrombosis or pulmonary embolism, liver dysfunction and cholestatic jaundice, or even vision disturbances, all of which are rare but can happen with prolonged use.
So we're just gonna send her home and wait till she comes back as a victim of incest?
We can't do anything unless the daughter comes forward.
Yeah, the mother should definitely have a talk with her daughter and come forward with everything that's happening with her dad.
We can try to talk to her, but if mom doesn't want us to...
I will talk to the mom, okay? Then we'll just take it from there.
Dr. Robbie is a true professional here, a good doctor in all respects, and won't shy away from doing all the necessary things to help patients in every way possible.
They keep dilating until it takes the largest catheter.
Why didn't we try ECMO on Mr. Milton, my gallbladder guy?
We said this before. It's done only in select patients and if the cardiac arrest was immediately witnessed with little to no downtime. A good candidate for an ECPR or an ECMO in cardiac arrest would be a patient whose cardiac arrest has been witnessed immediately as an initial shockable rhythm like ventricular tachycardia or ventricular fibrillation, or a non-shockable rhythm like pulseless electrical activity but not a systole. The CPR should have been started quickly within 5 minutes of the arrest, and high-quality CPR should be ongoing until the initiation of ECMO. Additionally, there should be short low-flow time, ideally less than 60 minutes, meaning the total time from cardiac arrest to initiation of ECMO cannulation should be less than 60 minutes. Most importantly, the cause of arrest should ideally be reversible, like for example a massive MI like this case, or a pulmonary embolism or myocarditis or a drug overdose. Other favorable criteria would be age less than 65 with no significant comorbidities. These favorable conditions are important to be considered for ECMO because they all suggest that CPR has been started on time and a lot of brain damage has probably not occurred to the point beyond salvation, so ECMO can buy enough additional time for heart and lungs by doing their work artificially and keeping the brain alive so that they could potentially and hopefully resume their functions again somehow during this bought time. We all know brain injury begins after 3 to 5 minutes of no perfusion. Even with CPR, only 20 to 30% of normal cerebral perfusion is achieved, and ECMO can restore perfusion, but only helps if irreversible damage hasn't already occurred in the brain, otherwise it would be worthless and useless. Here, this particular case is ideal because the cardiac arrest, which was a shockable rhythm in VFib, was witnessed immediately, CPR was started immediately upon arrest with zero delay, and ECMO was initiated within few minutes of the arrest after failed defibrillation, with the CPR still ongoing till the start of ECMO cannulation and is still ongoing. And yes, it's a reversible cause, with MI being the cause of the VFib, and MI's ischemia can be reversed, or at least further necrosis can be prevented with percutaneous coronary intervention and balloon stenting of the blocked coronary artery, hopefully reviving the heart's normal rhythm in the process as well. The gallbladder stone case before had a systole and was not immediately witnessed as no ECG monitor was there in the hallway. So there was quite some downtime before CPR was initiated, and at that time the patient's brain was already hypoxic beyond salvation, and ECMO would be worthless to administer at that point since the brain is essentially dead.
For ECMO, you need CPR within 5 minutes and an initial rhythm of VFib, VTEC, or PEA.
Which he had none of.
No.
ECMO in cardiac arrest or ECPR shouldn't be used if asystole is the initial rhythm upon detection of cardiac arrest and it went unwitnessed and was prolonged, meaning CPR was initiated late after a long arrest time, if no reversible cause is found, and if 30 to 60 minutes of CPR have already been administered without return of spontaneous circulation.
Do you need anything, Mrs. Kitajima?
I need to use the bathroom. I'm afraid I may need some help.
Oh, no problem. There's one nearby.
Being in the medical field doesn't always mean you have to constantly deal with medication dosing and procedures. Sometimes little things like this, or even just talking to patients, can help them a lot.
Should I grab the interpreter device?
Let's see how they do first.
Sam. Minu. Does it hurt?
She knows Nepali, she didn't understand what he said, I guess, and just smiled.
A stranger walked up to you, pushed you. I saw it. I'm gonna help cops find person who did this to you. They won't get away with this.
Raksha.
Raksha means protection, and she's holding the symbolic statue of God, trying to say God will protect us no matter what.
It's Vishnu, protector and guardian of the universe. Okay, Minu. Time to take you up to the OR.
Good luck.
She should have already been in the OR. I guess it's been 7 hours since the reduction. She was one of the first patients in episode 1, I guess.
2 catheters have to get attached to the ECMO lines with no air bubbles. You see what's happening?
Good to go.
Circuit on. And clamping.
So, as we've said before, this is a veno-arterial ECMO, meaning the venous blood is taken out from the right femoral vein here, then it passes through the membrane oxygenator to get oxygen and remove carbon dioxide, then the oxygenated blood is pumped back into the left femoral artery, hence bypassing both the function of lungs and the heart, reducing their workload and providing time for the ischemic heart to hopefully recover its normal sinus rhythm once MI gets treated with PCI. Meanwhile, the brain is still being oxygenated and is alive.
Okay, it's venous blood out the right femoral into ECMO for oxygen, then pumped back into the left femoral artery.
Stop the Lucas.
What's the map?
74.
So they've stopped the CPR machine as it's not required now that ECMO would function as eCPR, taking over as artificial heart and lungs. MAP means mean arterial pressure here.
Excellent.
So the ECMO is taking over for the heart and lungs. Once they open up the blocked artery, they can restart the heart. It's basically good as new.
That's why we look for reversible cause of arrest to start ECMO, because there is hope that the heart would revive back once the cause is treated, and then the ECMO can be stopped.
Incredible.
I'm sorry you have to do this.
It's okay.
My daughter would have helped me. I don't know where she is.
She's probably going to be back soon.
The kids are such a handful.
Their grandchildren?
Sometimes it's just too much, but my husband's busy with work.
Your husband...
She only has a daughter, I guess. She has lost touch with reality, and this is likely from her ongoing schizophrenia.
Did you take your medication today, Ginger?
I'm finished.
Okay.
I should get home. I need to start making dinner.
Hopefully it won't be too much longer.
You can go in if you want.
Will he be okay?
Yeah. Yeah, he just needs to stay in the hospital for a few days.
And then he comes home.
Yes. So your mom said that high school's been kind of hard for you?
I guess so.
Yeah, it was hard for me too.
Starting off with a casual conversation before diving into the uncomfortable stuffs.
Especially when things sucked at home. Do your parents put a lot of pressure on you?
Not really.
Are you and your dad close?
Yeah.
Has your dad ever made you feel uncomfortable?
What do you mean?
Has he ever done anything to you that didn't feel right? Even if you pushed it down or tried to forget about it because it didn't seem like a big deal? It may seem harmless for him to go into the bathroom when you're taking a shower, but it's not.
Where is this coming from?
And if it's more than that, if he is touching you anywhere that you don't want to be touched.
Why are you asking me this?
I'm just trying to make sure that you're safe.
He's my dad.
The daughter doesn't appear to feel the same way about her dad as her mom projects, but maybe she's not mature enough to articulate what's happening. Hence, it needs a proper legal investigation of its own, and hence the case overall should also be reported to concerned authorities.
I need to find my mom.
Alana, wait.
Dr. Robbie?
Yep.
Lab's all good on our influenza patient. Tox-3 negative, head CT normal.
Head CT.
She had memory problems, tremors. I had a hunch.
Well, she's had $1 million workup now. So.
I very much resonate with the psychiatry workup being very expensive. On the one hand, we gotta rule out all the organic causes before labeling it as a purely psychiatric disorder, but on the other hand, we end up sending every possible test we know of because we fear we'll miss out on anything, making the workup oftentimes much more expensive than it should be.
I can't refuse her.
But
being a good doctor, Dr. Mohan, is knowing when to dig deep and knowing when to move on.
I guess Dr. Robbie's point here is that it takes a little more symptoms and signs than numbness and tremors to merit a CT scan head.
Ready?
How are you doing? Okay.
I still can't believe this is happening.
Of course. Seems like a lot of people showed up for Nick.
Everyone came.
We needed this. We needed people.
It's the only way to get through anything in life. You have to lean on friends and family.
Nick's friends kept talking about what a kind person he was. When he registered to be an organ and tissue donor, he made the decision to save 8 lives and improve hundreds more.
It's almost impossible to know when parents are ready for such talks right after the passing away of their son. Parents can be aggressive if it feels too early to be talking about transplants and all.
Nobody should ever lose a child. But Nick's gifts could help other parents avoid the pain that you've experienced today.
I just need a little more time. I'd like to talk to Father McGill.
Okay.
It's worth stressing that a child's loss is much more painful than an adult's loss, and it would be even more painful to think their organs would be taken out of the body right after a sudden, untimely loss of their beloved only son.
How's your influencer?
She's been cleared for psych, but she keeps saying something's wrong. It doesn't feel right to me.
Listen to your patient.
What else could be wrong in the patient that suggests some underlying cause? I guess even the urine drug screen also came out to be negative here.
That is your superpower.
But Robbie told me to move on. I finally got on his good side.
Robbie's off today. Trust your gut. I'll back you up.
Well, there's no fracture, so it is just a sprain.
Basically meaning the x-rays have come back to be normal.
Sprains usually take about 6 weeks to fully heal.
The treatment for an ankle sprain typically caused by ligament injury would include RICE, meaning rest, ice, compression with wraps or ankle brace as is shown here, and elevation if there is significant swelling, along with pain meds and physiotherapy. Most ankle sprains recover in 2 to 6 weeks with proper care and rest.
Can you hold this like that for me? Of
course.
Weight bearing has actually been shown to speed up the healing process.
Early functional rehab with physiotherapy and weight bearing leads to faster recovery and lower risk of recurrence, while prolonged rest or immobilization delays healing and increases stiffness, although rest is important initially for the first few days.
This is what NBA players wear during games after an ankle sprain. Do you want to walk around, see how it feels?
I believe this will suffice.
Your labs and your brain scan are all normal.
So then what's wrong with me?
We're having a psychiatrist come talk with you.
You think I'm crazy?
A psychiatric illness could just be causing your symptoms.
If a patient says that, you don't double down and tell her that she could have a psychiatric illness. The patient is already in shock and perhaps even angry that her doctors came to that conclusion. So calm her down first and show empathy.
You have to believe me. Please.
So there is unilateral trembling of the hands, meaning only the left hand is specifically trembling. This could suggest a local cause of the symptom rather than a CNS symptom, which would rather cause a generalized effect.
Take me through your skincare routine. Don't leave anything out. Write this down.
So, I start off with a double cleanse. Next is the essence. I learned it from a Korean beauty influencer. Then a serum.
Do you use products from other countries?
Some of the best stuff is from overseas. They have better products for skin brightening and removing wrinkles.
You don't have wrinkles.
They'll be here before you know it. Don't do that. You need to watch your 11s.
Do you have photos of these products?
Of course, I post everything that works for me.
Can you show me?
The doctor is suspecting faulty skincare products for causing these symptoms, both local and psychiatric, I guess. The patient is being taken for a PCI, where the blocked coronary artery, which is the left anterior descending artery in this case, would be ballooned and stented to relieve the obstruction and prevent future blockage. Hopefully it would revive the heart's rhythm back as well, and ECMO could be removed.
What do you want to do?
We wait.
A 12-year-old needs this. He's been on the ECMO for 17 days.
Oh, that's too long for the artificial lung and heart to take over the body to just keep the brain alive. If there is no reversible cause, ECMO is of no use. It has to be let go eventually.
Dr. Mohan, may we speak for a moment? I thought psych was taking over.
I haven't called him yet.
I got 5 patients back here that haven't been seen yet. 51 more in the waiting room.
I'm thinking this is a toxicology case.
Everything is pointing to new onset schizophrenia.
So, schizophrenia is a diagnosis of exclusion. When every possible organic cause is ruled out, it would be the diagnosis.
So what zebra are you hunting?
She's been using a face cream from Asia with a high mercury content. This could explain all her symptoms.
So we're looking at a differential diagnosis of mercury poisoning here. Skin lightening products may contain high concentrations of inorganic mercury salts, such as mercurous chloride or ammoniated mercury, and users like the patient in question can absorb toxic doses daily, especially when applied over large skin areas or damaged skin. Inorganic mercury, which is absorbed transdermally, accumulates in skin and could cause peripheral neuropathy, which could explain the unilateral numbness and tingling sensations, along with trembling of hands seen in the patient. However, the most important manifestations occur when it travels via blood, crosses the blood-brain barrier, and accumulates in the brain. It disrupts dopaminergic and serotonergic neurotransmission, causing psychotic symptoms like hallucinations, delusions, mood changes, and paranoia. Hence, chronic exposure is linked to mercurial psychosis, also called erethism or Mad Hatter's disease, often characterized by irritability, insomnia, emotional lability, and memory loss along with psychosis. Bilateral tremors are more common and are due to CNS involvement, not local involvement of nerves. The tremor is called the Hatter's tremor, and it's a coarse, jerky tremor of the hands. It is an intention tremor and hence reflects cerebellar involvement of mercury poisoning.
Look, the FDA website has a list of imported products that contain mercury. She's been using this one. I've ordered a heavy metal panel looking for mercury, lead, or arsenic.
That's a really good observation here. However, it again adds to the expense of the patient. And Dr. Robbie likely wouldn't be happy, I guess.
Why didn't you consult me?
I consulted Dr. Collins.
Dr. Collins is not supervising this case.
I know. I just didn't know if...
If what?
I thought you were having a bad day.
Oh, she just messed up really bad. That definitely can't be the reason not to consult the ER attending for any case in the ER.
Did Dr. Collins say that?
No, she was just trying to help.
Don't ever do that again.
Elevate to stop the swelling, ice for 20 minutes twice a day, and wear the ankle stirrup until the pain is gone, and for another 6 weeks whenever doing anything athletic.
Basically explaining the rise, rest, ice, compression with the stirrup, and elevation. Also add weight bearing and physiotherapy to this for speedy recovery.
Any questions?
No, I'm all set.
And sorry we got off on the wrong foot. That was a joke.
I understood your intention. Is Dr. King around?
She might be with another patient.
Will you tell her goodbye for me? She's a very good doctor.
That's really sweet from the patient to the treating doctor.
Right. Sure, yeah. And good luck with your table tennis tournament.
Thank you. If you ever find yourself in South Park, I'll teach you how to play.
Okay.
Did you sign off on a heavy metals panel on new onset psychosis?
What?
Samira's patient. I cleared her for psych. You overrode me?
If Samira put it in order, there was a reason. I trust her. Maybe you should too.
I'm trying to break her these bad habits and you are enabling.
No, you're...
It's better to add up few investigations rather than miss the whole diagnosis and have the patient suffer due to it, especially if there is a legitimate reason to do so. Also, another aspect of this is, if you miss the diagnosis, you might be liable for litigation. So, a few more investigations now, despite the expense of the patient, would rather help than hurt for both the patient and the doctor.
riding her so hard. She's starting to lose confidence. It's affecting her. I told her not to take it personally.
What is that supposed to mean?
Really?
What?
You have been snapping at staff all day. And even though you won't admit it, I'm pretty sure it's because today is the day Adamson.
Oh, for
See? Can't even be honest with yourself.
All right. You're right. I don't want to be here today.
Then don't be. Or leave your baggage at the door like everyone else, but don't take it out on the rest of us.
Okay.
I don't think he's being mean. He is affected by the death of his colleague, but he's been nothing but reasonable. Also, keeping aside their past history with each other, it isn't acceptable to talk like that as a resident to a senior, let alone the attending of the ER who's in charge.
Since you're giving out feedback, I have some too. You are a rule follower in an environment that requires flexibility. You let fear drive your decision making, and you have no respect for your superiors.
I do agree. Telling the ER attending who is your senior to get out of the ER and leave his baggage at the door is crazy disrespectful, and I can assure you that never happens in real life scenario, or else the resident gets fired. You can't talk like that to anyone at the hospital, not the staffs, even if you think they aren't doing their job well, let alone your senior or an attending.
Superiors, wow.
I give you a lot of leeway, but I'm your attending and you are the resident, and you need to remember that.
Okay. Dr. Rabinovich, thank you for your feedback.
Dr. Robbie?
What?
Poor girl. She's on the receiving end of the displaced anger of Dr. Robbie here.
Kiara's ready for you to talk to the wife of the trauma 1 patient. With the wife, should I?
I'll handle it.
What's next?
Dr. Robbie will explain everything. Dr. Robbie, Susan Dunn.
Hi.
Hi.
Okay, so your husband is going to be admitted to the ICU, and if everything goes well, then we'll extubate him and the chest tube can come out.
A traumatic hemothorax with intubation does require monitoring in the surgical ICU until the patient's vitals are stable and no other complications arise during the monitoring there, in which case the patient would be extubated and shifted to the surgical ward, and the chest tube can also be removed.
But he's going to need to stay in the hospital for 3 or 4 days.
Thank you. I'm gonna take Alana home, but I'll be back later.
There's one other thing. Dr. Santos filled us in on your conversation. What you did to your husband is against the law. So unfortunately, we're required to report it to the police.
Police? I wasn't trying to hurt him.
Even so, this is where he ended up.
To Dr. Robbie's point, it was deliberate poisoning with the progesterone pill, and he could have ended up with its own complications in the ER too. And that's definitely medical legal.
I would suggest that you speak to somebody about your feelings and talk to your daughter. If there is something happening at home, she'll need to know that you're willing to listen.
We have resources I can provide, which include connecting you to the authorities.
We'll be fine.
We're doctors and we have to report any wrongdoing, and we would help prevent any other wrongdoings if the patient cooperates and is willing to come forward.
So that's it?
Hopefully now that it's out in the open, she'll take the necessary steps to handle this the right way.
But
Don't fight me on this. Focus on what you can control, your patients.
Dr. Robbie handled that well here. That's pretty accurate. We can control the patients and their diseases, not necessarily the familial issues. We can help as human beings, but we're not in charge of the law department, so it's not in our domain of control or expertise.
You okay?
the mother could be arrested and the daughter would be left alone with her dad.
I know it's hard. If you need to talk to someone...
I'm not the one who needs to talk. Okay?
As unfortunate as the situation can be, we as doctors can't control everything. We could notify the concerned authorities about the alleged abuse as well and help the mom get necessary help.
Your ankle guy was looking for you.
Oh, sorry I missed Terrence.
You were great with him.
I know what to say, I guess. Maybe how to say it.
Because of your sister?
Yeah. I know she's in a good place. I really miss her.
Yeah, well, you're obviously really good at helping people. You're crushing with your patients. You even taught me a couple things.
Really?
For sure. You're making a great first impression.
That's great to hear it from your senior. She's very empathetic and kind and compassionate to her patients and doesn't rush. And that's a great attribute to have as a doctor.
Wait out here.
Okay.
There he is. Remember me? So I talked to your wife and daughter about your extracurricular activities. Yeah, it didn't say in your chart that you were a child molester. Yeah, they told me about your bathroom visits and your massages, you piece of shit. So this is how this is gonna work. You are never going to touch your daughter again. You are never going to look at her or even think about her inappropriately, or Officer Ahmad out there is going to arrest you. And the only in your future will be the one you get in prison, you sleazy fat. Blink twice if you agree to this. Once if you want me to let you die. I've already lost 2 patients today. One more's not going to make a difference.
While she is doing this on moral grounds, feeling unjust about nothing happening, in real life scenario, it's not prudent to take a potential legal matter into your own hands and confront the patient like this at all. If anything, tell everything you know about to the police and let them do their work.
Good. Don't and don't your daughter. Oh, and I expect an excellent patient satisfaction score. Get well soon, Mr. Dunn.
And also definitely don't threaten your patients in any way, no matter how you think they are as a person. They might sue you over misconduct and you might be stripped of your medical license. Take help of police as per needed, but don't take matters into your own hands.
Thanks. Mifepristone.
You sure you want to do this? Yes.
So, finally the mom agreed and provided the legal consent for her daughter for medical abortion. As said in earlier episodes, the process of medical termination of pregnancy involves taking 200 milligrams of mifepristone, which is an antiprogestin that dislodges the implanted fetus and makes uterus unfavorable for continuation of pregnancy. And then after 24 hours, misoprostol is taken buccally, sublingually, or intravaginally, 800 micrograms or 4 tabs each, 200 micrograms, which is a prostaglandin E1 analog used to induce uterine contraction and expel the fetus while also ripening and dilating the cervix for passage of the expelled fetus through the vagina.
Second dose in 24 hours, then misoprostol.
I guess it's just a single dose of 200 milligrams of mifepristone taken once.
Everything's in here if you forget. Good luck to both of you.
What'd you say to her?
Something about not losing Christy forever.
Well, you gave him a chance.
That is going to be one long drive back to Tennessee.
True that.
Yeah, the counseling given to her mother definitely worked, convincing her for allowing the abortion. Bleeding during pregnancy could be a sign of miscarriage or spontaneous abortion if the gestational age is less than 28 weeks, and antepartum hemorrhage if it's more than 28 weeks till the delivery. This is likely a sign of spontaneous abortion, and it's a very unfortunate situation for her. Could be a case of ectopic pregnancy or molar pregnancy as well that can cause bleeding in early pregnancy.